This is GI Disorders and Therapeutic Management, Part 2. I need to get up to slide 21. Fulminant hepatic failure or acute liver failure. Mortality of 75 to 80%. Causes are in a box on page 855, but they include things like infections, drugs, and toxins. The treatment is a transplant. In pathophysiology, it's a syndrome of acute liver failure that develops over 1 to 3 weeks, with the development of hepatic encephalopathy within 8 weeks in a previously healthy liver. Hepatocellular necrosis generally occurs in patients with pre-existing liver disease. This usually takes only 2 weeks to develop due to necrosis of the hepatocytes. Causes of fulminant hepatic failure with the associated signs and symptoms. You'll have impaired bilirubin conjugation, so you have jaundice. Decrease in your clotting factors, which causes hemorrhage and coagulopathies. You'll have a decrease in glucose synthesis, so your blood sugar will drop. You'll have decreased lactate clearance, so you'll have metabolic acidosis. Altered metabolism, which leads to a decrease in albumin, edema, fluid and electrolyte imbalances, portal hypertension, and hepatic encephalopathy. You'll have cerebral edema and increased intracranial pressure due to breakdown of the blood-brain barrier. Arrhythmias due to acidosis, low oxygen levels, low potassium, and cerebral edema. Acute lung injury due to pulmonary edema, aspiration pneumonia, and atelectasis. And acute renal failure due to acute tubular necrosis, hypotension, and hemorrhage. On assessment, you'll find that they have a headache, they're hyperventilating, jaundice, personality changes, palmar erythema, in other words, the palms of their hands will be red, spider nevi, little spider veins, you'll notice particularly on the abdomen and the face, bruises, edema, asterixis, which is a liver flap or inability to maintain a fixed position of the extremities when they put them out. Hepatic encephalopathy, and there's a box on page 855 that talks about the different staging of hepatic encephalopathy. They'll have an elevated bilirubin, AST, alkaline phosphatase, ammonia, and protime. The protime will be around 40 to 80 seconds greater than the controls. They'll have low albumin, low blood sugar, potassium, sodium, platelet count. Their platelet count may drop down below 80,000, and respiratory alkalosis or metabolic acidosis. The medical treatment of fulminant hepatic failure is to prevent infections. Maybe give them a prophylactic antibiotic. If they want to lower the ammonia production in the bowel by giving neomycin. One of the side effects of neomycin is hearing loss and renal failure, so you have to be aware of that. Lactulose has a laxative effect, and it decreases bacteria in the bowel by causing an acid environment and trapping of ammonia in the bowel, causing diarrhea. And you do not stop giving it when they get the diarrhea, because this is how they're getting rid of the ammonia. If they develop cerebral edema, they'll need intracranial pressure monitoring. And to decrease that cerebral edema, they'll administer albumin and hyperventilate the patient and administer mannitol if there's no renal failure. Elevate the head of the bed 20 to 30 degrees. Treat the fever and the hypertension and decrease the stimuli. Prevent bleeding. Administer fresh frozen plasma, platelets, or vitamin K. Treat your symptoms. They may need a ventilator. If they go into acute renal failure, use continuous renal replacement therapy. They may need a PA catheter for fluid management. Nursing care, protect them from injury because you cannot use sedation. Because sedation will mask your neurological symptoms and may worsen the hepatic encephalopathy. You may need to restrain your patient. Observe closely for complications like respiratory depression and arrest. They'll need neurochecks every hour. Bleeding tendencies you'll have to watch for. fluid management, nutritional needs, emotional support. They may need information on liver transplant. Nursing diagnoses are on page 856, and patient education is on also on page 856. There was a patient who came in, 33 years old, came into the emergency room, fulminant hepatic failure, had not been ill, was dead in 10 days. He needed a transplant. There wasn't one available. GI surgery and esophagectomy removes part or all of the esophagus, stomach, and lymph nodes for cancer treatment. And there's a figure on this on page 857 and 858. I'm just going to pause for a second. A pancreatic duodenectomy, or a Whipple procedure after the doctor who performed it. There's a figure for this on page 854. This is also for pancreatic cancer. It removes the head of the pancreas, the duodenum, the common bile duct, the gallbladder, part of the stomach, and the jejunum. And sometimes it works. Bariatric surgery might be done. Now, your restrictive decreases the capacity of the stomach. You can either have a vertical band gastroplasty, which we talked about, or gastric banding that's laparoscopic and is reversible. And I see a lot of that advertised over the holidays. Malabsorptive surgery alters the digestion and absorption of food. Your Roux-en-Y gastric bypass, there's a picture of it on 859, it also decreases the size of the stomach. And you've got your biliopancreatic diversion, and there's a figure for that on page 859. When you're talking about surgery, you need to think, are they going to have a transhiatal or a transthoracic incision? If it's a transhiatal, the incision will be in the neck. Transthoracic will be in the chest. Will they have an NG tube? If so, don't manipulate it because they will suture it in place, and you don't want to pull on those sutures. They will have a chest tube in place. To prevent complications such as atelectasis and pneumonia, you're going to use a PCA with either morphine or Dilaudid so that you can use the incentive and cough and deep breathe this patient and ambulate them and do pulmonary toilet and maybe even have a ventilator for them. For anastomosis leak, this can cause sepsis, multiple organ disease, dysfunction syndrome, and death. Symptoms are an increase in heart rate, respiratory rate, temperature. They'll have abdominal pain. They'll be anxious and restless. They'll have sub-Q emphysema. It's treated by keeping them NPO, giving them antibiotics. If it's a small amount, drain the fluid. If it's a large amount, take them back to surgery. DVT, pulmonary embolism, they'll have EPC cuffs on. They may have a greenfield filter implanted. They may receive IV heparin or low molecular weight heparin as a preventive measure to start with. For the bleeding is very uncommon. This is usually treated with a histamine blocker or PPI. Nursing diagnoses you'll find on page 860. Now, some of the things you might use to manage GI bleed would be GI intubation with either a Levine or a Salem. Now, this is used very easily, very often, very commonly. You need to irrigate it every 4 hours with normal saline. You keep the air vent open and above the level of the stomach. The purpose is to remove the stomach contents or obtain specimens, to decrease the accumulated swallowed air, to give tube feedings, to decompress the bowel, and to decrease the risk of aspiration. But you need to prevent ulceration and necrosis of the nares, the dry mouth, the loss of fluid and electrolytes, and to assess closely for correct placement. There is a box on page 862 that talks about care of an NG tube. And page 861 to 2 talks about legal and safety problems associated with nursing management. So you need to read both of those. Esophageal gastric balloon tamponade is something that may be done. Now, this is inserted by a physician. The 16 Blackmore has 3 lumens. The Minnesota has 4 lumens. The Linton necklace also has 3. It's connected to traction by way of a football helmet. And you need to reassess for bleeding, esophageal erosion and rupture, and aspiration. And it is usually deflated every 4 hours for 15 minutes for the first 24 hours, and then it's deflated permanently after 24 to 48 hours to prevent necrosis. Now, the gastric portion may remain inflated for up to 72 hours. But when you go to remove this, you have to deflate the esophageal balloon first. Then you wait for 24 hours to make sure they're not still bleeding. And then you deflate the gastric balloon. And then you wait another 24 hours, and then the physician removes it. Now, some long intestinal tubes that are used are your Miller-Abbott, your Cantor, and your Anderson. Now, the Miller-Abbott and the Cantor use mercury pouch, so they're not used as often. Anderson uses tungsten and weighted tungsten tip, so it's used more often. Again, the purpose is to remove the contents of the intestine and to decompress the bowel. This uses peristalsis to advance it, and so therefore, if you have no peristalsis, as in an ileus or an obstruction, you cannot use them. As I said, the Miller-Abbott and the Cantor contain a mercury pouch. The Anderson contains the weighted tungsten tip, and that's why we're using it more often. And you can only remove 6 inches every hour, and the nursing care is the same as for the other tubes that we have discussed. Feeding tubes are usually a size 8 to 12 French. The jpopp is the one that's used most often. It's a very flexible, has a stylet inside of it, and has a weighted tip with that guide wire. You need to check the placement with x-ray and mark the tube at the nares before you remove the guide wire, because once you remove that guide wire, you cannot reinstill it. You activate it by instilling or flushing the whole system with some water. The directions come with it. You elevate the head of the bed 30 to 45 degrees when you're giving tube feedings, and you check that residual every 4 to 6 hours and reinstill it. Additional therapies that you might use, you can do an intramucosal pH or PHI monitoring. This uses a tube similar to an NG tube and checks the pH of the gastric mucosa similar to that of blood. And it will decrease due to anaerobic metabolism and decrease blood supply to the gut. Medications are on a table on 867 to 8, but they include things like your antacids, your H2 blockers, your gastric mucosal agents, your gastric proton pump inhibitors, vasopressin, which decreases blood flow and decreases portal flow, and sandostatin, which decreases portal pressure. You can cause either hypo or hyperglycemia. And that finishes this portion, except for one comment. In the past, we used to put food coloring into the tube feeding so that if the patient aspirated it, we would know by the color of the aspirate. And the only thing it really did was cause severe diarrhea. So it is no longer recommended that you put any food coloring or any sort of dye into the tube feeding solution because it really didn't do what we thought it was going to do.